That's a good question. As we started this work, trying to understand the problem of diabetes in our context here, one of the areas that we looked at keenly was the health system and the services. We've done some formative studies, mostly in Uganda at health facility level, and we've discovered that a broad range of services are lacking, and I would classify them under three main categories. The first one is diagnosis and entry into care. The second one is the quality of care. And the third one is the retention in care. So, and I'll briefly describe what we've observed in each of these areas. So regarding entry into care, the current guidelines, both clinical guidelines and other guidance available for diagnosis of diabetes, mostly assumes that a person is very ill. So for you to catch a diabetes patient, whether it is type 1 or type 2, you'll have to get them when they are substantially ill.
That's true.
Right from the guidelines, they say the signs of diabetes is drinking too much, eating too much, gaining too much weight, or too much loss of weight. But we realize that by that stage, a person is already very ill. And normally what brings them to the facility is that they have either collapsed, or they're severely ill, they're down and bedridden, or they've got some major complication. That's the first time they touch point with the place where maybe a suspicion is gone. The reason why this is happening, first of all, is the clinical guidelines are not sufficient to enable clinicians to know how to suspect diabetes. Two is that the healthcare workers, in their training, basic training, they don't get sufficient training and exposure to diabetes. So they don't have sufficient awareness
and understanding.
So what we found down there is that a diabetes patient, they will move up and down, interface with the health system, go back to the village. First time maybe they are diagnosed to have malaria or pneumonia. Then they go back to the village. Then they are not improving. They go to a drug shop. They are not improving. They go to a traditional healer. Next time they go to, so then they come back to the health center. Then when things are really bad, that is when they go to the hospital. That could be 1 year down the road, 1 year. And so many things happen during 1 year. So by the time they come to the hospital, they have collapsed. They have severe diabetic ketoacidosis with many complications, some of them near death, and we lose many of them in the early stages. So the diagnosis, the clinical suspicion, but also the readiness of the health facilities, the first point of care health facilities, to detect that this person probably has diabetes. They don't need to know that they have diabetes, but they suspect and they refer appropriately.
That's
that one we need. The second thing is the entry into care. And the initiation of care and quality care. We've realized that, first of all, the diagnostic tests for type 2 diabetes are not easily accessible at the lower levels. The primary care, the basic primary care test, which is fasting plasma glucose, in many primary care facilities is not there. The first point is the hospital. And at the hospital, they have a very narrow choice. Some patients do not have the money to keep, like for instance, if they need to do a fasting plasma glucose to confirm, they don't have the money to keep going and coming back. So many of the facilities rely on a random blood sugar, which they mix with the clinical symptoms. So there's the issues of getting accurate diagnosis. The other beta tests like the hemoglobin A1C are not available at that level at all.
That's true.
Then when they are initiated into care, the quality of care has many problems. Right from the medicines, we found that in Uganda, the medicines rapidly get stocked out. The medicines that are supplied are so low in comparison to the patient load. So you find that because the first line medications, the oral medications, that is metformin, which is supposed to be everywhere. It's a basic drug. It's relatively affordable, very affordable even for our context. There are multiple stockouts of the drug. Then you come to the second line, glibenclamide or related drugs. They are not there. They come for short periods. The patients complete them, and then they are not drugs.
For months, they are not there.
And then comes the insulin. Insulin is quite costly. The access to insulin is and it's very quickly wiped out. Sometimes you have some types of insulin stocked and others not stocked, and yet they need to combine both. And then when they take the insulin home, the storage is a problem. We've talked to patients who store insulin in a pot under their bed because they think that's the coolest part of the house. So we need more stable insulins that are not affected by storage at room temperature, but these are not accessible. And then the quality of patient support, the health education that they receive. They don't get sufficient information regarding, first of all, their condition, 2, what to expect, 3, how to take care of themselves. This is lacking. It's provided in bits and pieces. It's not standardized. We were surprised to learn that at primary care facilities and up to the hospital, there are no standardized health education materials to help healthcare workers to educate the patients. So they give them very contradictory information. I'll take an example of some patients we talked to who say they were stopped from eating anything sweet, including fruits, including sweet bananas, pineapples, and that. But then they say when they went to a higher level referral facility, they told them, no, you should eat these, they are good for you, but eat in small, limited amounts. So then the patients have this very confusing information. We found diabetes patients have been told not to eat sweet potatoes. The thinking is that because they are called sweet potatoes and they taste sweet, then they have a lot of sugar. So we have patients in Uganda, where sweet potato is one of the key staple foods. They are not eating sweet potatoes. Others have been stopped from eating almost everything. They say almost everything. They've been stopped from eating rice, cassava, sweet potatoes, and then they're anything that is starchy. So then you wonder what they eat. Some of them end up losing a lot of weight. These are some of the challenges in care. And then after that, the follow-up. When diabetes patients leave the health center, that is the end until the next visit.
That's true.
In Uganda, at the hospital level, we found the diabetes patients are required to get a care companion who helps them to take the medicine. But that's as far as they go. There will be no further support, no following up to find out whether they're taking the medicine, no linkage between the healthcare worker and the diabetes patient in the home until the next visit, which is probably 1 month later. And then the third area that I wanted to highlight is the retention into care, and it's related to the follow-up. We found that many diabetes patients, when they get better, because when they've been ill for a year, and then here they are given medicines, either insulin or what, they rapidly get better. When they get better, they think they are healed, and then they will not come back. Until the next time they come back, they've suffered a major problem. So there's the follow-up, the health education about the disease itself, so that they know. The support in the home. Some patients told us that they face a lot of pressure from their family members because they have to undergo a special diet, and yet it's a stress on the family, the food preparation and the food environment. So that disruption, it causes some friction in the family, issues of eating low salt, eating low sugar, not frying, reduced fats in the food. All these disrupts the dieting patterns of the family. So there's that strain. So the follow-up support, we found that some diabetes patients have clubs where they encourage each other, but the club activities stop at the health center. When they go back to the communities, there's no connectivity to keep themselves encouraged. So that's another challenge. So broadly, there are quite a number of challenges at all levels, both from the patient side and the health system side, that need to be addressed.
You mentioned earlier about psychosocial support.
Yes.
And I've realized a lot, you're right, by the way, a lot of diabetics actually need a lot of psychosocial support, because very quickly when they look for answers, and it's taking them years and years to get those answers, they get so frustrated. So if you're not educated, you're going to suffer so many frustrations, because the truth is diabetes changes every day. Your blood sugar changes with what you eat. It changes with what, it changes with, for example, what activities you do. It changes with the medication you're taking or not taking. So if you're not educated, the frustrations are so many. And that means at the end of the day, most of them just give up and they get ready. They're like, I'm ready to die. What am I doing here? I'm not here to suffer.
You are right on that. From maybe before that, I'll talk about one critical element that I didn't talk about, and that is blood sugar control. Blood sugar control is central to the well-being of the diabetes patients.
I agree.
And if blood sugar is well controlled, actually diabetes sufferers can live a relatively normal life. But with blood sugar control, you need, first of all, the medicines, the appropriate medicines in the right doses and at the right time. But also you need the self-monitoring of blood glucose. Okay, general monitoring of blood glucose, but which could include self-monitoring. That stops in Kampala. When you go to the more rural areas, access to glucometers for people to monitor their blood sugar, especially even the more critical, a careful tracking of their blood sugar. They don't have access to glucometers.
That's true.
So in Uganda, first of all, we found diabetes care is mostly tertiary level. At tertiary level, they have to go to the hospital. At the time we went in, the hospital was the only level that provided regular diabetes care and had a regular diabetes clinic. And there they had one glucometer. One glucometer shared among 350 diabetes patients. The test strips would run out. Occasionally, the national supplier for supplies would bring test strips that don't correspond to the glucometer, and all that would be wasted. The patients they've tried to navigate around some of these issues. They contribute money. They've created a small group, circle, so they contribute money and they're able to buy the test strips. But a test there, a blood sugar test will cost, if they go to the private clinics, it will cost 5,000 shillings, which is approximately about $1.50. And yet, a glucose test strip costs $50. Just about 700 shillings a test strip. They will pay 5,000 shillings.
That's almost 5 times actually no more.
Yes,
about
7 times the actual cost of the test strip. So there's that challenge of access to self-monitoring. But now coming to the issue of psychosocial health. Chronic diseases are associated with psychosocial health challenges. People get worried for many reasons. They get worried about the illness, but also they get worried about the burden from the illness, the medication, the burden of medication, those on insulin, the burden of injections, but also the when they get to learn that the disease is not curable, the burden of what will happen next, then the burden of complications. So all these things play together to create worry, sometimes resulting in severe worry, anxiety, sometimes even driving towards depression.
Yes.
So we've found that diabetes patients need counseling as part of the package.
Yes.
Like has been done for HIV/AIDS, where counseling was made part and parcel of care.
Yes.
The same thing needs to be done for diabetes and indeed for other chronic lifestyle illnesses, but more so for diabetes because of the burden of morbidity that they have.
Yes.
So statements in the we are about to publish a paper, and the paper, the title, the first part of the title is a quote from a diabetes patient which says, "What type of life is this?" And then other patients told us that they feel that they would rather have HIV/AIDS compared to type 2 diabetes. Others told us that they have a lot of worry. Some of them have lost their hope. But in the same patients, we found patients who are well activated, energized, they are very optimistic, and they were doing well. Their blood sugars were well. They were caring for themselves. Some of them had bought glucometers, others were working together. So we are asking ourselves, what are the factors in these patients that are not in the other patients who are very worried?